Hello everybody! In this video we'll talk about osteoporosis and osteoarthritis medications. First, we'll talk about the pathophysiology of osteoporosis. We have osteoclast cells which break down bone tissues while the osteoblasts build bone tissues. In osteoporosis, the osteoclast activity exceeds osteoblast, leading to bone fractures. In women, reduced bone formation happens because of estrogen deficiency during menopause, which will increase osteoclast activity. Men are at lower risk of developing osteoporosis because they have larger bone size and greater peak bone mass. For the symptoms, many patients are unaware that they have osteoporosis until they have fracture. The goal of treatment is to stabilize or improve bone mass and strength and prevent fractures. For osteoarthritis, it usually begins with damage to articular cartilage through injury or excessive joint loading from obesity. Damage to cartilage increases the activity of chondrocytes, which are cells responsible for cartilage formation, in an attempt to repair damage, leading to increased synthesis of matrix constituents with cartilage swelling. Normal balance between cartilage breakdown and resynthesis is lost with increasing destruction and cartilage loss. Now, cartilage loss will cause joint space narrowing and painful deformed joints. The remaining cartilage will soften and develop fibrillation, followed by further cartilage loss and the exposure of underlying bone. New bone formation, which are called osteophytes, will form at joint margin. The predominant symptom is deep aching pain in affected joints. Pain will increase with joint activity and will decrease with rest. For drug therapy, the target is relief of pain. First, let's start with the osteoporosis treatment. We need to increase the bone mineral density so we can give calcium supplementation, which should be given with vitamin D since it can maximize calcium absorption. We have calcium carbonate, which contains the highest concentration of elemental calcium by 40%, but should be taken with food since it needs acidic environment to increase the absorption. Then we have calcium citrate, which has acidic independent absorption but less elemental calcium, only 21%. For vitamin D, we can use cholecalciferol or ergocalciferol. Then we need to decrease osteoclast activity, so we have bisphosphonate, denosumab, and calcitonin. For bisphosphonate, like aldoronate and risedronate, they inhibit bone resorption, which means it decreases osteoclast number and activity, and it became incorporated into the bone, giving them long biological half-life for up to 10 years. Aldoronate can be given weekly, while risedronate can be given monthly or weekly. Each oral tablet should be taken in the morning with 1 cup of plain water for at least 30 minutes before consuming any food, supplements, or medication. The most common adverse effects include nausea, abdominal pain, and dyspepsia. Esophageal, gastric, and duodenal irritation, perforation, and ulceration or bleeding can occur. The most common adverse effects with IV bisphosphonate include fever, flu-like symptoms, and local injection site reaction. Rare adverse effects include osteonecrosis of the jaw, which happens more with cancer patients receiving high doses of IV bisphosphonate. Denosumab, which is a rank ligand inhibitor that inhibits osteoclast formation and increases its apoptosis. It is administered as subcutaneous once every 6 months. Injection adverse effects include back pain, eczema, cellulitis, and infection. It is contraindicated in patients with hypercalcemia until the condition is corrected. Then we have calcitonin, which is an endogenous hormone released from thyroid gland when calcium is elevated. It inhibits the activity of osteoclasts. Salmon calcitonin is used clinically because it is more potent and long-lasting. For low estrogen levels, we have Raloxophene and Prxofine, which are estrogen agonists on bone receptors but antagonists at breast receptors. They are approved for prevention and treatment of postmenopausal osteoporosis. Hot flushes are common with Raloxophene but decrease with Prxofine. Leg cramps and muscle spasm are common with both. Now, to increase osteoblast activity and number, we have Theriparatide, which is a recombinant human product of human parathyroid hormone. It increases bone formation and osteoblast number and activity. It is contraindicated in patients at increased risk of osteosarcoma and should not be used in patients with hypercalcemia or metabolic bone disease other than osteoporosis. Now, for treatment of osteoarthritis, the goal is to relieve the pain. So first, we have acetaminophen, which is preferred first-line treatment. After that, we have NSAIDs, which is recommended if patients failed acetaminophen. Topical NSAIDs are recommended and preferred over oral NSAIDs in patients older than 75 years to avoid NSAID side effects. Then it is preferred to use COX-2 selective inhibitors to avoid GI adverse effects. If using non-selective NSAIDs, then we should use the lowest possible dose and use PPI or H2 receptors antagonists with them. After that, we have intra-articular corticosteroid injection, which are recommended when analgesia of acetaminophen and NSAIDs are suboptimal. Initial pain relief may occur within 24 to 72 hours, with peak relief occurring after 7 to 10 days and lasting to 4 to 8 weeks. Local adverse effects include infection, osteonecrosis, tendon rupture, and skin atrophy. It should not be used more frequently than once in every 3 months. Tramadol can be used in patients who are inappropriate candidates of oral NSAIDs and who are not able to receive intra-articular corticosteroid. Tramadol is associated with opioid-like adverse effects like nausea, vomiting, and constipation, but not associated with life-threatening GI bleeding or cardiovascular events. Tramadol is classified as Schedule 4 of controlled substance due to its potential of dependence. Opioids are used for patients who are at high surgical risk and cannot undergo joint arthroplasty, but it should be used in lowest effective dose and in smallest quantity needed. Duloxetine can be used as an adjunctive treatment in patients with partial response to the first-line treatment like acetaminophen and oral NSAIDs. Pain reduction occurs after 4 weeks of therapy. It can cause nausea, dry mouth, constipation, and anorexia. Intra-articular hyaluronic acid acts as a lubricant and shock absorber in the joints. It's not routinely recommended because it has shown limited benefit. Injections are well tolerated, but acute joint swelling, effusion, stiffness, and local skin reaction have been reported. And that's the end of this video. Please don't forget to subscribe, share, and like.